अवस्था होना चाहिए आपको, नहीं? लेकिन आई हैव टेस्टेड, इसमें आवाज आ रहा है, ये चालू हुआ है कि नहीं मालूम। आपको दिखाऊं मैं आवाज आ रहा है? It's okay. You also can speak. You can ask this, you are audible. The types are come. Yes. So he's connected from the class, no? Yeah, he's coming. Okay. It's okay. My
Okay. Hello everyone. Hello. IP.
एक मिनट।
Dr. Namkyu, you have very beautiful background. So I think it is 3. We should start. Everybody, IP is here.
IP, Dr. IP needs to unmute himself. Dr. Sung-Pil.
Yes, I'm here.
Okay, yeah. Welcome back. Dr. IP.
Dr. Eiichi will be joining in few minutes.
Okay. So I think Professor Sinha, if you could start the.
Okay. So good afternoon to everyone. On behalf of Asian Australian Society of Neurological Surgeons, Neurotrauma Committee, I welcome all the speakers and attendees on this webinar. Today, our speakers is Eiichi from Japan, IP Cherian from India, Namkyu from Korea, and Sung-Pil Joo is also from Korea. And we have very important topics for this meeting. And they are all very important because in everyday TBI patient management, they are very helpful. And every speaker will be given 20 minutes for presentation and 5 minutes for discussion. And we are two moderators, myself and Dr. Amit Chakravarti, who is senior neurosurgeon in my city. So can I request Dr. Amit Chakravarti to start the our meeting?
Thank you, Professor Sinha. So with this, we would be starting the webinar on behalf of Asian Australasian Society of Neurological Surgeons. And we have 4 speakers lined up for the day, all eminent speakers. The first speaker of the day is Professor Eiichi Suehiro. He is the professor in Department of Neurosurgery, International University of Health and Welfare, School of Medicine, Chiba, Japan. Professor Eiichi is a recipient of many awards. To name a few, he has received the Hirakawa Award of the Japan Society of Neurotraumatology in 2017. And he was also invited for the Presidential Citation of Neurocritical Care Society, the 15th annual meeting in 2017. He also has more than 45 national and international publications to his credit. Today, he shall be talking about the risk of late exacerbation and the effects possibility of reversal for geriatric traumatic brain injury patients with antithrombotic agents. So Professor Eiichi, please could you?
Could you see my slide, everyone? Okay.
Yes.
Okay, so hello everyone. So I'm Eiichi Suehiro from International University of Health and Welfare in Japan. And so actually, so I moved here from Yamaguchi University last April. So today, my topic is a study on the risk of the late exacerbation and the effect possibility of reversal for geriatric patients of traumatic brain injury treated with antithrombotic drug. So this graph shows the aging rate in each country. Among them, Japan has risen rapidly and has become the most aging country in the world. In other words, Japan will be a model case for aging medicine. This graph is from the Japan Neurotrauma Data Bank. It shows the aging rate of severe TBI patients in Japan. As you can see, the aging rate is increasing year by year. And surprisingly, recent data show that more than half are older than 65. Here, I will explain the characteristics of TBI patients in the elderly. Elderly people have cerebral atrophy and subdural space expands. As a result, the hemisphere become more mobile and the impact can damage bridging veins and cause subdural hematoma. Also, most importantly, the dilated subdural space allows the presence of a small hematoma to be mild and asymptomatic. Originally, the initial GCS is widely used to assign TBI severity, but is poorly predictive of morbidity and mortality in older adults. This shows the rate at which elderly people with clear consciousness show abnormal finding on head CT. Then it can be seen that even if the consciousness level is good, the rate of showing abnormal finding is much higher in the elderly than in the young. In other words, head CT should always be taken in the elderly, even if it's a mild head injury. Even if the symptoms of hematoma are minor, symptoms rapidly becomes severe after reaching the threshold value in geriatric TBI patients. So this is a pitfall in the treatment of geriatric TBI patients. This shows the talk and deteriorate frequency for each age group from Japan Neurotrauma Data Bank. As you can see, the frequency is increasing in elderly. Another problem with older people is antithrombotic drugs. Atrial fibrillation atrial fibrillation prevalence rise with age. The elderly with anticoagulants will increase for the purpose of cerebral infarction prevention. The incidence of cerebral infarction also rises with age, and the elderly with antithrombotic drug will increase for the purpose of cerebral infarction prevent. This is an oral rate of antithrombotic drugs in elderly patients from the Japan Neurotrauma Data Bank. It can be seen that about 30% of patients are taking antithrombotic drugs. This shows the mechanism of injury depending on the oral status of antithrombotic drugs. The results show that the group of patients taking antithrombotic drugs was significantly more injured by falls. This also shows the frequency of having bleeding lesions. Significantly more bleeding lesion in the group of patients taking antithrombotic drugs. This is also comparing the frequency of talk and deteriorate. Interestingly, we find that the frequency of talk and deteriorate is significantly higher in the group of patients taking antithrombotic drugs. Similar reports were seen from the United States at exactly the same time. A retrospective observational study at Level 1 Trauma Center was performed, and 1,365 head injuries, including mild cases over 65 years, were enrolled. To summarize the result, the group of patients taking antithrombotic drugs were older and more falls, more hematoma, and more hematoma expansion and poor outcome. So actually it's the same as our result. This is a protocol for reversal therapy for antithrombotic drugs for patients with TBI at my previous facility, Yamaguchi University. Active use of prothrombin complex concentrate for warfarin and 10A inhibitor, and idarucizumab for dabigatran, and platelet transfusion for antiplatelet drugs. So reversal therapy was given to all patients with bleeding, even if they were mild. So therefore, the effect of reversal therapy on antithrombotic drugs was examined at the Yamaguchi University. The subjects were 101 TBI patients hospitalized between 2013 and 2018. 22 patients were taking antithrombotic drugs. And the reversal therapy was performed in all these cases. And we compared and examined the following item between these two groups. As can be seen from this table, the group taking antithrombotic drugs was older and had more faults and more acute subdural hematoma. So actually, this result was consistent with previous reports from Japan Neurotrom Data Bank and from the United States. This is a treatment content and a clinical outcome. In previous report, the frequency of talk and deteriorate was higher in the group of patients taking antithrombotic drug, but no difference was observed between the two groups in this study. So this result was thought to be the effect of our aggressive reversal therapy. So next, we conducted a questionnaire survey of facilities participating in the Japan Neurotrauma Data Bank regarding reversal treatment for patients with head injury who are taking antithrombotic drugs. First, we asked about the frequency of reversal therapy for warfarin at each facility. For warfarin, it was found that the reversal therapy was performed at a high rate at each institution. Based on this result, the institutional group that performed reversal therapy with a frequency of 80% or more was divided into the active group. And the institutional group with less than 80% was divided into the non-active group. And the frequency of talk and deteriorate was compared between these groups. Then it was found that the talk and deteriorate was significantly suppressed in the active group. We also investigated the frequency of reversal therapy for DOAC, but the overall rate was low. And then divided into two groups in the same way. So more than 80% divided into the active group and less than 80% institution divided into the non-active group. Then in DOAC, the frequency of talk and deteriorate was lower in the active group. So finally, a similar study was conducted on the antiplatelet drugs. The frequency of reversal therapy was generally low for antiplatelet drugs as well, and divided into two groups in the same way. Similarly, the talk and deteriorate was suppressed in the active group. So according to the guideline from the United Kingdom, the reversal agent for warfarin recommended according to the value of PT-INR like this. And the reversal agent for warfarin, vitamin K, and fresh frozen plasma, and prothrombin complex concentrate, and recombinant activated factor 7. So according to the same guidelines, idarucizumab and activated charcoal and hemodialysis and active prothrombin complex concentrate recommended for thrombin inhibitors. And activated charcoal and active PCC and andexanet alpha recommended for 10A inhibitors as reversal agents. So finally, and desmopressin and platelet transfusion at the time of surgery recommended for antiplatelet drug as reversal agents. So here is a schema of head trauma for the elderly taking antithrombotic drug from my thinking, my thought. First, hit your head against something. And it is just mild head injury. However, the hematoma spread over time and rapidly becomes severe and becomes a brain herniation. So brain herniation, as you know, is an irreversible brain injury with a poor outcome. However, if it's detected early in a mild head injury, it can be brought to a good outcome by appropriate treatment. For early detection, it is important to first take a CT of head. And next, confirmation of the presence or absence of hemorrhage lesions. And if there is hemorrhage lesions, take appropriate treatment like this. And if there is no hemorrhage lesions, according to the reports so far, if there is no abnormal finding on the initial head CT, the frequency of finding abnormal finding on the second CT is very low. So actually 1% or less. So this is a summary of my talking today. The elderly patient can cause traumatic intracranial hematoma by the low energy trauma. Even if significant neurological symptoms are less, there is a high possibility of intracranial lesions. The elderly TBI patients taking antithrombotic drugs had a significantly higher prevalence of both intracranial bleeding and the talk deteriorate. So it's important to appropriately respond to those patients before deterioration and to reverse the antithrombotic drugs. Thank you for your attention. Thank you very much.
Thank you, Professor Eiichi,
Mhm.
for a nice and detailed presentation. I have one question. When we talk of antiplatelet medication, so the commonly used antiplatelets are aspirin and clopidogrel. And in some cases, a dual antiplatelet is also given for those who are having cardiac complications.
Mhm.
And as we know that clopidogrel, the duration of action is around 5 days.
Mhm.
So if any patient is on clopidogrel, and
Mhm.
if we try to reverse the effect with fresh platelets, will it not again destroy the platelets or have a like inhibit the platelet activity? Will it be of any use if we give fresh platelets?
First question, first answer for first question is in Japan. So recently, so clopidogrel is more common compared to aspirin, and so yeah, so recently about 80 or 90% of patients have a clopidogrel, and 1 or 20% has aspirin. And so now you are talking about platelet transfusion. So I know, so it's still controversial. So actually, so the guideline from the Neurocritical Care Society, so actually, so recommend only for surgery, for after surgery. So actually, so we don't have answer yet, but now we just challenging the aggressive reversal treatment, and so like as show the result in my slide about from survey. So actually, so platelet transfusion may be effective, but still we don't know exactly. So now we are challenging.
Yeah, it's a gray zone. It's a gray zone.
Yeah, that's right.
So I think the clinical correlation and the need of the hour for surgery would be the main decision makers.
Mm-hmm. Yeah.
Yeah.
That's right. Yeah. But so most important thing for platelet drug, antithrombotic drug. So maybe so from I read the report from the United States. So they measure the platelet function, and they reverse. I mean, they put the platelet transfusion according to the result of platelet function. So it's a very interesting study.
So platelet function at your center, do you believe more on the bleeding time itself, or you like to go for other more complex tests?
That's right. It's big problem. Actually, so now, so no standard measurement. So I mean, no standard function measurement over function. So we have to find the method of that.
Fine, thank
Can
you.
I ask, Amit?
Yes, Professor Sinha.
Yes, any any role of tranexamic acid and platelet pools for, do you use tranexamic acid?
Platelet. I'm sorry, platelet.
Platelet pool and tranexamic acid.
Yeah, actually, so still we don't know about that yet. So I'm sorry.
Okay, do you have any protocol of drugs if a patient getting this clopidogrel or warfarin or
okay.
aspirin. So which is the best antiplatelet the drug or reversal? Which is best drug which can use for reversal?
So basically, it depends on the pathophysiology of a stroke, So if it's an embolic stroke, so we use warfarin, and it's not embolic stroke, so we use antiplatelet drugs. And so in my slide, so I show the protocol for reversal therapy. So basically, we use that protocol, aggressive protocol.
And if there is some emergency, patient is deteriorating, and so there's the bleeding time is more, clotting time is more, INR is more. So what you do in these cases? So the patient deteriorating.
Yeah, it depends on the patient. So we judge for each patient. So
Okay.
now we don't have a protocol
Okay.
standard method. And so
Okay.
yeah,
Thank you.
thank you.
Some of the dilemmas would continue. So with this, thank you, Professor Eiichi, and we move on to the next speaker of the webinar, Professor I.P. Cherian. Professor I.P. Cherian, could you please start your video, please?
Dr. Ripe is just coming in a couple of minutes, stuck up in a surgery. It just take 10 minutes, sir. Can we have another speaker at the moment till then?
Fine. That should be fine. So Professor Namkyu, okay, fine. So he's also there. So Professor Ipe would be joining us shortly, and we move on to our third speaker of the day, Professor Namkyu Joo. He is the professor of Ajau University School of Medicine, Suwon, Korea. He is assistant professor and spinal neurosurgery division in neurotrauma division, Suwon, Korea. His areas of interest in spine is spinal trauma, spinal cord injury, deformity surgery, and spinal revision surgery. For brain cases, he is interested in traumatic brain injury and emergent brain surgery. Today, he would be talking about intraoperative ultrasonography in TBI. Professor Namkyu Joo, over to you.
Okay. Okay, thank you for gentle introduction, Chairman. Today I talk about the intraoperative ultrasonography. I'm from Namkyu, from Ajau University, South Korea. Okay, this is my early case of TBI. After this initial CT scan, I decided to do craniotomy and hematoma evacuation first. But after hematoma removal, brain was rapidly bulged out. So I closed wound very fastly and transferred the patient to CT scan. First of the CT scan showed frontal epidural hematoma newly developed and brain herniation. So I decided to second operation and the patient sent back to operation room. And this is the last CT scan of this patient. And the herniation was recovered, but some hematoma was removed. But between the two surgeries, the patient spent more than 1 hour. During the surgery or hematoma removal, we may meet rapid progressive bulging of brain. In that time, what is the cause of bulging brain? Is it due to brain edema, or is it due to contralateral hematoma progression? In this moment, intraoperative imaging is helpful for decision about next step. Now, we already know and use many intraoperative imaging methods: fluoroscopy, CT scan, MRI, and sonography. Fluoroscopy provides simple plain X-ray and low-quality tomography scan in some models, and also used in angiography with contrast media. It makes radiation exposure. Fluoroscopy is not suitable exactly suitable intraoperative imaging in general TBI surgery. CT scan is most familiar to neurosurgeon. It used widely, but produce much radiations than fluoroscopy. And it needs time and some effort to use in surgery, such as sterile draping and evacuation of surgeons. And during CT scan, surgeons are hard to doing any procedure. MRI is most detailed imaging modality. It provides high quality brain image, but MRI scan needs time and effort, such as operation field protection.
रुक गया उसका okay we are unable to hear you
The imaging method. Its mobility is wonderful and minimal restriction by place. It can be done in any operation room, but it needs some learning curve to get used to it. Echogenic imaging is not familiar to most neurosurgeons, and ultrasound could not penetrate hard materials and skull. Now I show that how to prepare intraoperative ultrasound scan. First, you have to prepare ultrasound machine and probes to scan. To ultrasound scan, operator should know about its adjustable parameters. It looks like that of digital camera. You can control several parameters: gain, echo power, focus, and echogenic dynamic range. This is my intraoperative ultrasound preparation. Probes are covered with sterile vinyl drape. It is filled with sonographic gel. Sonography may be controlled by circulating nurse or other colleagues, but I recommend that operator have better to control himself for good EMG and rapid scan. I usually use two types of probes. One is 90-degree angled sector type probe. This probe showed best view for midline to contralateral area. Other one is linear type probe. This is good for magnified ipsilateral side to midline view. And now I show short video how to do ultrasound scan. And now I talk about the sonographic scan sequence. This is a scan sequence like CT axial scan. First, axial view scan from caudal to cephalad, then coronal view from anterior to posterior side. Now I explain about the ultrasound findings in several cases. Contralateral hemorrhage or bilateral hemorrhage is common situation in TBI patient. This case is an epidural hemorrhage at left side, and also since subdural hemorrhage at right side was found. After removal of epidural hematoma, ultrasound showed no progression of subdural hematoma at right side. Post-operative CT showed same amount of subdural hemorrhage. The patient was recovered without additional craniotomy. I show two cases. Above case was right side subdural and epidural hemorrhage with left temporal countercoup contusion. Left temporal contusion was scanned during surgery and it was not progressed. Second case, intraoperative ultrasound scan detected small contusional hemorrhage development after subdural hematoma removal near tentorium. This case is an acute subdural hematoma with severe herniation. After hematoma removal, there was no brain bulging, but sonography showed intraparenchymal hemorrhage at ipsilateral basal ganglia and brainstem. It also found in post-operative CT scan. This patient was diagnosed as acute subdural hemorrhage at left hemisphere. After hematoma removal, ultrasound showed frontal lobe contusion, intraventricular hemorrhage at third ventricle. And also same degree of midline shifting was observed in both ultrasound and post-operative CT scan. Ultrasound also useful in real-time navigation for hematoma removal. In this case, during bilateral craniectomy, right side frontal intracerebral hemorrhage was removed on the ultrasound guide, and temporal lobe contusion was also resected by ultrasound guide. In this video, you can see a high echogenic catheter in lateral ventricle. With an adequate angle of ultrasound probe, stereotactic catheter insertion is possible with ultrasound. Brain swelling and herniation also can be monitored during the surgery with ultrasound. Midline shift and ultrasound is similar in post-op CT scan. With sector type probe, it showed limitation for ipsilateral near side inspection. In this case, coup contusion were not exactly identified with ultrasound. So, second probe is a linear type probe for near side scan. It provides magnified view, and also it can detect subdural hematoma before dura open. Cerebrospinal fluid showed low echogenicity with bright cerebral cortex, but subdural hematoma is high echogenicity with dark cerebral cortex. Magnified ultrasound image can detect small cortical injury injury, which may not be seen in CT scan. Like ultrasound image shows small contusion at cerebral cortex. It may useful detect small contusions. And post-op CT scan, there is not exactly contusion, but MRI scan showed same cerebral contusion. Now I show contralateral hemorrhage progression after hemicrectomy case. 70 years old female patient who was struck by a baker. Initial mental state was coma and Glasgow coma scale was 5. First, I did right side subdural hematoma removal and hemicrectomy. Then intraoperative ultrasound showed right hemispherical swelling, and midline shift was measured in 11.6 millimeters. During closure of dura mater, cerebral cortex was swelling rapidly. Then I decided second sonographic scan. Ultrasound showed newly developed epidural hematoma, contralateral side. And I reviewed the post CT scan, and I find small linear fracture at temporal bone. So I continue to next operation without patient transfer at the same operation rooms at the same time. So I found acute epidural hemorrhage and then remove it. This is another case. Left side acute subdural hematoma was found and removed, but there was a progressing brain swelling. Ultrasound showed contralateral acute epidural hematoma. I do rapid test bore at contralateral side, and acute hematoma was pumping out. Most ultrasound machine provide Doppler or power color Doppler mode. Doppler can detect blood flow rate. Color mode provide vessel patency. Is in these midline epidural cases, Doppler showed no visible injury in sagittal sinus. The patient was recovered without neurologic sequelae. Intraoperative color Doppler provide also vasospasm or blood flow. This result may helpful for judging to ICP control after surgery. If you have to plan to start intraoperative ultrasound, first you should learn control and set ultrasound machine, and prepare intraoperative use with sterile drape. Then do test scan in elective surgery such as cranioplasty. This is conclusion. Intraoperative ultrasound may be the powerful method in TBI surgery. It is cheap, can use in anywhere. Patient and surgeons are not exposed to radiation. And some situation, it may replace post-operative CT scan and will save time to next step or surgery. But ultrasound is not familiar to us neurosurgeons, so our effort is needed. If it has risk of mechanical insult and infection, but I have not experienced yet. And ultrasound scan can be done best in craniotomy status without scar. This is N. Thank you for listening.
Thank you, Professor Namkyu Yoo. Very impressive presentation on the use of this real-time navigation device. It is indeed a great boon for surgeons, a new armamentarium in their kitty. I just have one question. The intraoperative ultrasound probes which you are using, are they specific for cranial ultrasound, or you have also tried the general sonography probes which are used for other parts of the body?
I use general sonography machine, not special to neurosurgery. I use the small probe. It is usually used for cardiac echo, and another probe is used for peripheral blood procedure.
Okay. So the probes which you were using were not very specific for cranial ultrasound, which are some of which are available in the market.
Yes, I generally used the ultrasound machine. It used in internal medicine or gynecology also.
Okay, so that is very encouraging because it means another investment. So you can always start with the general ultrasonography probes. So very nice to hear that.
Thank you.
We have one question from Dr. Hitesh. That how do you sterilize these ultrasound probes once they have been used in the surgery with the proper draping and all? Then do you again sterilize them, or like the microscope? You just
I the probes I used is not for gas or heat sterilization. I used vinyl sterilite drape only.
Okay. So something very similar, the way we use our microscopes
Yes.
and our endoscopes.
Can I ask something, Amit?
Yes, yes.
Yes. Namkyu, first, thanks for your excellent presentation.
Welcome.
And just I want to ask this: there is a lot of problem seeing the posterior fossa content by ultrasound, right? So midline
Yes.
you can see, but what about the lateral part? So what is your experience?
Your opinion is exactly right. The ultrasound has provided somewhat low quality from the long distance from probe, especially in posterior fossa. And another anatomical barrier, tentorium probe inhibit the ultrasound. So in that case, I moved to ultrasound probe to toward the near to the posterior fossa. It is more small, a little more good image providing.
Okay. Second question: do you use this ultrasound in all the TBI cases, or there are some risk factors in CT where you use?
Pardon?
Do you use this ultrasound in all TBI surgery
Ah,
cases,
yeah,
or
yeah.
there are certain risk factor where you choose?
I try to use ultrasound in all my TBI surgery, and the others are some in my, as in my presentation, and catheterization in patient with craniectomy status.
And the next question is: do you use contrast enhanced ultrasound like this sulfur hexafluoride is very good for which give the good microcirculation view. So do you have any experience of that?
Yeah. I know about the ultrasound contrast agent, but not used well because it is some expensive and needs some time to injection. But TBI pay surgery is mostly in emergency situation, so I have not used the contrast media.
Okay, last question. I don't have any experience. We don't have experience of intravascular ultrasound in TBI. If you know, it's okay.
I have not experienced yet.
Okay.
Yeah, I have no experience.
Okay. Thank you.
Yeah, thank you.
Thank you, Professor Namkyu. We move on to our next speaker, Professor Eiichi Cherian. I suppose he needs no introduction, but still, Professor Eiichi Cherian is the director in Institute of Neurosciences, Krishna Institute of Medical Sciences, Karad, Maharashtra in India. He is the General Counselor of Asian Congress of Neurological Surgeons. He is member of Anatomy Committee, World Federation of Neurological Societies, and he is the inventor of Cisternostomy, cleaning and cooling theory. Professor Eiichi, may I request you to start with your presentation on the role of cisternostomy in head trauma.
Thank you, Amit. That was a very kind introduction.
Thank you.
It is an honor to be with Professor Sinha and Professor Amit on this panel with all of you, all these speakers. Today, I am going to talk on my technique of cisternostomy and how things have changed for us in the last 13 or 14 years. I have to tell you that a lot of people ask me, what is the surgical technique of cisternostomy? you must understand, I mistook a head trauma for an aneurysm surgery because there was a, 14 years back, we didn't have these smartphones, and I had asked my junior chap to put in the aneurysm first and then the trauma. But then when I went there, what had happened is they had put in the trauma first, and because the trauma had dilated its pupils. So what happened is I operated on that trauma like I would operate a WFNS, let's say grade 5 fissures, grade 4 aneurysm. So I tried to get into the base. Then I tried to open the cisterns, got the brain lax. Well, one thing I did extra was to look for an aneurysm. Obviously, there was no aneurysm there, and after 1 hour, I started sweating. And that is when I remarked to my assistant that I can't find the aneurysm. And that is when the stoic gentleman told me that there's no aneurysm, this is a trauma. And well, everybody knows this. So it was easy on my part. I never considered that it is trauma. It was, there was a lot of subarachnoid hemorrhage, there's a lot of brain swelling, and all that. I looked at it, I thought that it was an aneurysm. And that's why I started opening cisterns. And this was 2006. And, I remember my first presentation was in Cambridge. I had 50 patients, partly from India and partly from Nepal, where I went to work by 2006 December. I didn't have any video recordings, and I went to Addenbrooke Hospital and I presented my data as if I was I made the most dramatic change in the world of neurosurgery. This is what I thought, and you wouldn't imagine. I probably did not understand English because my friend there, he told me that the English, the guys who were present there, they told me that it was interesting. That's what they told me. They told me it was interesting. So when they said interesting, I did not know that the English means that interesting means nonsense. So that was how I started off, I remember. And then things slowly changed. Thank you, Baba. Thank you so much. And things slowly changed. And in 2012, what we were talking about, that is the edema in a traumatic brain injury, is because the CSF went inside the brain. That started getting accepted because of Nedegard's and Elif's work. Let me share my screen. I figure that I haven't shared my screen. I'm sharing my screen. Can you see that?
Yes.
Okay. Now let's make it full screen. Yeah, I'm making it full screen. Okay. This is a common scenario all across the world, and you know what it is. And you see, after this, the subdural is taken out. This is the same brain, and this is what's happening. And for this, people do all kinds of hemispherectomies, and this doesn't happen very often, but if you ask the residents, they would have seen quite a lot, especially because countries like India, Africa, South America, and rest of the world where trauma is much more common. In a big hospital, they do at least 4 to 5 cases a day. And I'm sure in SMS Jaipur, where Dr. Sinha is working, must be much more. It's one of the largest neurosurgical centers in the world, if I may say so. So imagine this happening on a day-to-day basis. And if I tell you, this is completely avoidable, except when there is ischemia. If there is ischemia, we cannot avoid this because it's a cytotoxic brain swelling. But otherwise, this swelling, what is happening is CSF shift edema. You get into the cisterns, it can be avoided. But if you ask a resident to do it, it's impossible because a resident also cannot clip aneurysms, or a resident cannot also take out a petroclival meningioma and many more. So a resident cannot do it. So who has to do it? The consultant who has experience of operating on aneurysms. So I told the story of discovery of cisternostomy. That's how we discovered it. And I'm going to show you some initial cases. So you see, look at this scan. Look at how edematous this is. Patient came with a GCS of 4. Left pupil was dilated. Decompression of the temporal bone was done. So, our first 300 cases, we did a decompressive with a cisternostomy. And we found that the results were far better than a real decompressive alone, just a decompressive alone. So we did a decompressive, then for maybe another 100 or 200 cases, we started replacing the bone as a thin rim. After decompressing the temporal part, we started putting back. Now we don't do that also, we put back the bone. It was a process for us. Initially, we started decompressive with cisternostomy. Then we started decompressive, large flap, and then we took out the temporal bone. And after that, we used to put the parietal bone. This is one of those times, 2012, when we were putting a thin rim of bone back. You can see that thin rim. And you can see the brain is actually not there. The brain is there. And you can see the difference between the first scan, where he was M2, to the second scan is that all the cisterns are open. Okay, all the cisterns are open. And you see the guy. This is immediately after his suture removal. So this you wouldn't see with decompressive, I'm sure. Another scan. Bone kept back. Another scan. These are all initial period scans. See the midline shift, the mass effect, herniation, okay? Bone flap kept back, cisterns opened, and this is how the patient is. Another scan, bone flap kept back. Another one, you see the cistern, there's nothing, no cisterns at all. And so you can see this is what happened after that. Another scan where this patient was bilateral pupils. I remember this patient clearly standing in the emergency and trying to explain to her relative of her husband, telling her that there is absolutely no chance for this patient making it because she was M2 and bilaterally fixed pupil. And you can see the edema, you can see the midbrain, which is really compressed there. So in the post-op scan, you can see how much traction we had to put under that frontal lobe to get into the cisterns. You can see that's a traction injury. But that's better because this patient is almost back to normal. She's got a bone flap put back and she's back to normal. Okay. So she still had a third nerve palsy, but she was back to normal. Another one, you can see how the brainstem is shifted. Okay. You can look at it, the posterior fossa hematoma evacuated and cisternostomy done. Another one, very recent, okay? You can see the CP angle cistern is widened, large burst slope, okay? Frontotemporal burst slope, and very bad injury. You would have definitely done a decompressive. This is what was done by my consultants, not even done. Now we have a lot of people all over the world. There are groups from all over the world doing cisternostomy. Europe, we have Roy, and Italy. Italy, we have Antonio. We have Czech Republic. We have Chile. Brazil, we have Vaiga. India, a lot of people are doing it. I get WhatsApp messages, at least one every day, as to how somebody has done this. So this is the catheter sitting there, and this is the patient. Another one done from somewhere else, and this is how it is. You can see the catheter sitting there. Another one. You can see we started studying the circulation with ICG. It's very, very interesting. We'll continue that in Karat. Another one. This is how the brain was looking like, so tense before opening, after the subdural is opened, and after the cisterns are opened. From Czech Republic, showing that the ICP with cisternostomy dropped from 48 to 11 as soon as this, after the surgery. Another one, you see the kind of mass effect there is here. You can see the CP angle cistern, instead of that, it's widening here. See, this cistern is widening. This means herniation. Post-op, day 1 extubated, obeying commands. Another one. Because of the fallen GCS had to be taken up immediately. Okay, GCS was 15 by 15 at presentation. He fell down, and this was how the brain looked after cisternostomy. All done in separate centers, many places. Intraoperative pictures. That is the basilar, that is the optic nerve, carotid, third nerve. So after the cisterns are opened, this is the scenario. And the brain flap being, the bone flap being replaced. So what is CSF fifth edema? It's very simple. So that is a cistern. Let's imagine that's a cistern. That is your dura mater, your arachnoid, and your pia mater. That's a cistern. All the vessels are in the cisterns. So this is CSF. Now what happens when there is trauma? There is subarachnoid hemorrhage. And because of the subarachnoid hemorrhage, subarachnoid blood is a newcomer. And it gets into the cisterns and increases the pressure inside the cisterns. So what happens? These are the Virchow-Robin spaces where the CSF normally goes in for the cleaning and cooling. This also is our hypothesis, which is in textbooks and many journals, and has been quoted by Nature, Science, etc. We propose that for the first time, that the CSF is important for, in fact, the brain is a water-cooled and a water-cleaned system. So normally CSF is getting in this Virchow-Robin spaces. And when there is subarachnoid hemorrhage in this region, the pressure in the cisterns go up. And imagine about 120 ml of CSF, let's say at least 100 ml of CSF gets into all these Virchow-Robin spaces. And it's like injecting, take a Coke bottle, let's say a 1 liter Coke bottle, and try to inject about 100 ml of, let's say, tap water or something, or normal saline into it. It's impossible, you see. The kind of pressure that you will build up would be, you can't imagine how much that whole bottle might burst. That's what's happening to the brain. And after all that CSF went into the brain, what are we doing? We're trying to open a large flap so that that edematous brain can herniate into that that whatever opening we made. So literally, we are, instead of transtentorial herniation, we are making a decompressive flap and allowing the brain to herniate to that flap. So, but we're not addressing the intraparenchymal edema. So we've proved that in Calgary, CSF shift edema. So if CSF shift edema was true, that is a 7 Tesla MR in the background. And that is the weight model that we did this in Calgary. And we saw that there is T2-weighted hyperintensity. 15 minutes after the trauma, there was T2-weighted hyperintensity. We wanted to know whether that was CSF or that was blood. And we saw that blood was in the cisterns. The blood was there in the cisterns, and there was edema, severe edema, which was water in the brain. So a lot of people ask me, why don't you put in a EBD and remove CSF? It's because the ventricular system and the brain are not in communication. So this was proven beautifully by Elif and Nedagad. So they injected markers into the ventricle and markers into the system. And you can see the Varshavin spaces are lighting up. And the markers, in 30 minutes, the entire markers was in the brain. So these two compartments, that is the cisterns and the brain, they are communicating. While the ventricular CSF, ventricle and the brain is not communicating at all. So the only thing you can do by taking some CSF away from the ventricle is to play on the compliance. Imagine you blowing up a balloon, and at the last phase, for 1 ml of air, the pressure going up will be tremendous. So if you take out that 1 ml, pressure comes down. That is called playing with the compliance curve. That is what we are doing when you are taking CSF from the ventricle. Not very efficacious. So what you need to do, you need to open the cisterns and let out the CSF. So the brain is like a balloon which is communicating with that cisternal balloon. So then the edema comes down right in front of you. So this is Elif explaining about the CSF shift edema, and this is the model we made. We made it almost 12 years back. I have never changed this model because I like this model. You see, cisterns, subarachnoid hemorrhage, and the CSF goes into the brain. The CSF goes into the brain, and the brain swells up. So what you do is you drain the cisterns, and then there is a reverse shift of this CSF. It's called a reverse shift. We can see that straight. When you see a surgical video of cisternostomy, you can see it filling up, the CSF filling up. So in other terms, this is CSF shift edema. That is, the cisterns get into the cisternal CSF. After subarachnoid hemorrhage, the pressure here goes up. The cisternal CSF gets into the Varshavin spaces and causes edema. Open the cisterns, you will reverse that, and the intraparenchymal pressure comes down. Instead of doing that, do a calvarial, do a DC, and this is what happens. For getting into the base of the brain, there are some skull-based maneuvers like axial unlocking, sagittal unlocking. This is useful not only in cisternostomy, but all anterolateral approaches. We described this unlocking maneuvers, although this was there of course, this was there in practice before, but we described all the unlocking maneuvers, including the intradural unlocking maneuvers for the anterolateral skull base. So these are videos of, I'm going to skip these videos. You can see them on the net. This is the indication score of cisternostomy published World Neurosurgery. this is the importance of CP angle cistern widening. You can see if the CP angle cistern is widening, that means that there is impending herniation. And when the CP angle cistern is occupied, that means there is herniation already. And from this to this, motor score goes from usually from 5 to 3, and the prognostication is very bad. So when the CP angle cistern is widening, it's a good time to take up this patient if there are signs of raised ICP or signs of deterioration. CP angle cistern is widening, it's a very, very important sign. Well, these are the outcomes you can read. These are so many papers right now from all over the world. Anatomy and physiology. These are some of our initial papers. This is from Iraq, and this is from Iraq. There are papers from Iran also. This is from Switzerland, from another one from Switzerland, one more from Switzerland. Now the critics we have faced now, right now, we've faced a lot of critiques, but now the main critique is, saying that a resident cannot do cisternostomy, so let's stick to decompressive. This is what right now the critique is. And I'm sure leaders like Dr. Sinha and of course the other leaders are going to address this. Incompetence is not an excuse. I don't think incompetence has ever been an excuse in neurosurgery. So if you say that a resident cannot do cisternostomy, so he should not be doing it. Neither should he be doing an inferior procedure. This is like telling a WFNS grade 5 aneurysm came, so the resident or the junior consultant cannot handle it. So let him do a decompressive hemicraniectomy. This used to happen before, but no more. So it's time that this primitive surgery, which is holding center stage right now in trauma, while all other branches have moved on. And you must also understand that trauma is the largest part of neurosurgery, the largest part of neurosurgery. Trauma is treated like some secondary, people have a trauma theater where not much facilities are there, not even a microscope is there, and they think it is correct. It's not correct. It's time that we changed it. It's time that trauma came to microneurosurgery. So the critiques has been that, it's difficult to do. So we've been included in the GENOS. Slowly, it has been in the GENOS study, cisternostomy is an option now. And online registry and the multicenter trial is happening as we speak. It's happening already in US. Also, it started. Now I'll tell you a little bit about brain cooling and cleaning. Cooling and cleaning, that's interesting because you know how the brain is being cooled? This is our theory from 2012. You see the sinuses, all the sinuses, the ethmoid sinuses, the sphenoid sinuses, the maxillary sinuses, all these sinuses, they are lined with wet mucosa. And when you breathe, what happens is this wet mucosa gets evaporated and the latent heat of evaporation is lost. Therefore, making these sinuses cooler by 2.5 degrees to 4 degrees. So what happens? The suprasellar cistern is right on top of the sinus, in fact, in the center of the sinuses. So the suprasellar cistern is also cooled. So suprasellar cistern is the largest collection of CSF. From the ventricles, this CSF comes into the suprasellar cistern. And from the suprasellar cistern, all the vessels are going into the brain. So around these vessels, because of the pulsation of these vessels, it's an Archimedes screw principle. Because of the pulsation of these vessels, the CSF is being pumped from the cistern into the inside of the brain. You may think 10 years back, people used to laugh, but no more, because now this is proved. When we used to say this 10 years back, even in 2014, 2015, people used to laugh. But now there are so many studies which shows that CSF goes in by the pulsations of these vessels. So this is a cool CSF by the sinuses, and this CSF goes around these vessels to all parts of the brain by the pumping of these vessels. You know, one of the most important things that happens in Alzheimer's is the pulsatility of these vessels are lost. Degenerative diseases are the results probably, I don't know for sure, but degenerative diseases probably are because the cleaning and cooling pathway is not okay. That is the cooling pathway. In the night when we sleep, aquaporin 4 gates open up, and this Verschoeben spaces CSF also communicates with the ISF of the brain, cleaning out chloride, lactate, and other metabolites. That is the cleaning pathway. Cleaning pathway is active only in the night when you sleep. Cooling pathway is active all the time. Every time that you breathe, the suprasellar cistern is getting cooler. This CSF, the cooler CSF is being pumped around the brain for cooling. You see, this is something that we proposed for the first time. And how is it driven? It's driven by the pulsatility of the vessels. It's not by capillary action, it's by the pulsatility of the vessel. This is something when I went to Tours once, and I went to Leonardo da Vinci's museum and I saw the Archimedes screw, I suddenly realized that this is the way the brain is, this is what the brain is using to, pump the blood in, pump the CSF in. So you can see the sinuses, airflow there. These are all our diagrams. This is Voralax who made it. And this is the textbook diagram of how the cooling mechanism and the cleaning mechanism happens. This is Springer's neuroseries. And this is the chapter. I think it was somewhere in 2016 or something. It was put in as a chapter. This is the intake open. There's a chapter, another chapter. Okay. Thank you very much. I hope that was interesting.
Thank you, Professor Eiichi. I must say it was an interesting and innovative strategy for managing severe head injuries. And when I say interesting, I mean interesting, not the British interesting. So maybe just for the benefit of all the viewers over here, could you just summarize in a short way the sequence of steps for cisternostomy? Maybe in a very short way so that we all benefit from your talk.
Well, Amit, I'm very impressed by the musical instruments sitting behind you. Yes, so let me, for everybody who's listening, the most important thing that one has to realize is that I do these cases just like we will do an aneurysm. So it is very simple. Earlier, I used to talk about a lot of unnecessary steps, but they are not required now. So a lot of sphenoid ridge has to be removed. A lot of sphenoid ridge till you reach the lateral edge of the superior orbital fissure. So that is number one. So once you do that, then you open the dura at the base and go underneath the frontal lobe. So what you do is go under the frontal lobe above the orbital roof into the optic nerve. That is the first thing that you do. When you get there, there may not be any CSF. You dissect laterally to the carotid, and from the carotid dissect laterally to the third nerve. That is the first step that you do. Go underneath the, so this is exactly what everybody does for aneurysm surgery. Say ACOM, PCOM, IC bifurcation. Every aneurysm, they do the same thing. If the brain is tense, what do? You go subfrontally, you open the cisterns, you go to the optic nerve, then go laterally, go to the opticocarotid cistern, put suction on the opticocarotid cistern, put a lot of irrigation into the opticocarotid cistern, then you go lateral to the carotid and the third nerve. And sometimes, depending on whether the opticocarotid cistern is larger or the lateral carotid cistern is larger, you can go through that and open the membrane of Liliequist also. Once you open the membrane of request, you can see the basilar. Our resident had over 700 recordings of basilar taper. So while we were doing this, but we have much larger number of cases for cysternostomy. But we had the residents' thesis were rejected because it was of course too innovative at that time. So, but we had 700 recordings of basilar P1s and superior cerebellars. So we put in once we see the basilar, we put in a drain into the prepontine space. We wash out the blood and then we keep the drain for 5 days. This is what we do. I hope this helps, Amit.
Yes, it does help. We have another question from Dr. Raghu. He just wants to add that with the cysternography, do you also advocate a ventriculostomy, maybe an anterior third ventriculostomy?
Yeah, so I used to do this. Excellent question, Raghu. So I used to do opening lamina terminalis when along with the cisternal opening. And you know, during the time when Yuha was there with us for some time, and he also, when he was doing cysternostomies, he also used to say that, oh, you must open. But I think if there is no blood in the ventricle, one should not open, because you're introducing blood into the ventricle. This is not a good thing to do. When you are introducing blood in the ventricle, then the chances for hydrocephalus and other problems are more. So if you have a virgin ventricle, don't open the lamina terminalis. You can get very good relaxation by opening all the cisterns and being patient about it. If there is ventricular blood, then of course you can open the lamina terminalis and wash out. Okay, somebody is asking Barhol EVD. You know, I got a very interesting series from Switzerland. There was a chap called Tariq who was doing a EVD, and he was purposefully pushing that EVD a little bit more down. So it was a third ventriculostomy. They were saying that was better than the usual EVD. It was literally a cysternostomy. You see, he was getting into the third ventricle and oh, Raghu is asking cysternostomy with Barhol EVD. No. That is what Tariq was doing. But I don't know. I mean, maybe that would be a bit dangerous because you have the basilar tip there. So, and you are going through the third ventricular floor into the suprasellar cistern. Maybe it's better than a normal EVD if you can do it with guidance and maybe with an endoscope. But you see, in trauma, it is not an easy thing to get even into the ventricles. It's not easy. It's a squashed ventricle, and then you go through a squashed third ventricle, you'll be creating more issues. And I think easier would be a cysternostomy. Less invasive would be probably EVD, but easier, I would say easier would be a cysternostomy.
Can I ask something?
Yes, please.
Yes. This quick question. There are many different systems intracranially. I think infratentorial system is much more important than supratentorial systems.
Absolutely.
Yes, like CP angle system or cysternal or ambient is much more important to predict patient's outcome.
Absolutely.
Yes. Which system is? Do you think which system is the most important to predict patient's outcomes?
Yeah. So, what is your name? Sung-Pil Joo.
My name is Sung-Pil.
Yeah, you have hit the nail on its head, because when we were doing anterior cysternostomy without opening the membrane of Lilliquist, we had a 10 to 25% chance of the patient deteriorating after 48 hours. We called it the rebound deterioration. But when we started opening the membrane of Lilliquist and started getting into when we started getting into the posterior fossa cisterns, the prepontine cistern especially, we started having a much reduced rate of rebound deterioration. So now we put in a drain into the prepontine cistern. Our drain sits in the prepontine cistern. So you can see all our scans, you can see that the drain is just anterior to the basilar or in the CP angle system. So yes, it's extremely important. The posterior fossa cisterns are the most important part of this cysternostomy.
Okay.
You're right.
बोलो. We have one question from Fabia.
Yeah.
I suppose you have partly already answered it. Like, what is the strategy if the brain is blown up? Can we still do a cysternostomy? So you have partly answered that. Should you?
Yes, I mean, see, you can see some of these videos on the YouTube where when we open at the base, the brain is just coming out like toothpaste. But that doesn't matter. That is a little bit of damage to the basic frontal lobe. You don't have to really worry about that. Get into the cisterns, use the orbital roof as a guide, let the brain come out, use the orbital roof as a guide. This is a leap of faith. Believe me, this is a leap of faith, because for over 4 generations, we've been trained that when you have a tight brain, you have to close and come out. Not really. This is a leap of faith. So I'm telling you, we have done it, how much ever tight it is, except when there is ischemia. If there is ischemia, if the patient, I mean, this is cerebral blood flow. If the cerebral blood flow is really down and if there is ischemia, this cannot be done. That is why we started doing it in ischemic patients and we stopped it. And now the Italians have started doing it in ischemia, but in early phase, much before the edema really starts. So they've started cysternostomy for hemispheric infarcts and they're doing really good. I mean, I've never done this, but they are doing really, especially Massimiliano and this group has done very well. But otherwise, how much ever tight the brain is, I can tell you, we have seen all that. Brain will come out for a bit. You saw one of the cases where the brain was coming out. On scan, you could see the retraction injury. Get into the optic, get into the opticocarotid, wash out, and then wait. The brain starts going down. Okay. I can show you, there is a lot of videos on you. Just type cysternostomy on YouTube and you can see these videos where brain has been really tight and we can still do the cysternostomy.
Thank you, Professor Cherian.
My pleasure and my honor to be participating in this meeting. Thank you.
You are a very good teacher as well as surgeon, no doubt.
Professor Sinha, thank you. It's an honor and I'm hoping to see you sometime soon.
And have you made some guidelines regarding the cysternostomy or statistical analysis about the decompressive and cysternostomy and just information?
Roy has published the article about these guidelines, indications, and when do they do decompressive with cysternostomy. Now, Parthiban is also, his article is accepted, I think, in Neurology India. So this is also something about the guidelines and things. For me, I haven't personally published anything regarding the guidelines. So Roy and Parthiban are the two people. Now there is, from Shanghai, there is a chap called Wang. He's done extensive work on cysternostomy. He's got over 300 in 2 years back, he had over 300 cysternostomies. And he also has done a lot of work on the guidelines and combined ICU management as well as cysternostomy, both the best of both worlds.
Thank you, Professor Cherian. So with this, we move on to the last speaker of the webinar. May I welcome Professor Sung-Pil Joo. He is the chairman, is in Shanam National University Medical School and Hospital, Gwangju, Korea. He has many awards in his kitty. To name a few reputed ones, he has been named by IBC the 2000 Outstanding Intellectuals of the 21st Century, 9th edition. 2016-17 Who's Who, he has been ranked 30th in Science and Engineering, 12th edition. In 2019, in the Korean Cerebrovascular Surgical Society, he was given the award for the best paper. He has more than 66 international and 12 domestic publications. Today, he would be talking about antiplatelet management in TBI patient. Professor Sung-Pil, over to you.
Dr. Emmett, thank you for your kind introduction. First of all, I will share a presentation file I have made just before. It will take 15 minutes. Some contents I will present is overlapped with Dr. Sueheiro's lectures, so I think it is easier for listeners to understand. Hello everyone, my name is Sung-Pil Joo from Jeonnam National University in South Korea. Everything is okay? I'm going to talk about antiplatelet management in TBI, especially focusing on when and how to resume antiplatelet. Everything is okay? First of all, I'd like to show an example of TBI in elderly patients who has been taking a warfarin for 12 years due to atrial fibrillations. She presents with semi-comatose mentations after car accident. We can see the more aggravated midline shifting after immediate follow-up CT scan just within 1 hour. So we performed craniectomy and hematoma removal without hesitations. However, her mentation was the more deepened after surgery. Follow-up CT scan showed increased hematoma size and brain edema on the right hemisphere within 12 hours. She died in the end, unfortunately. Here is the signpost indicating different time points. There are three aspects to be considered. At first, we need to figure out the past history, why the patients have been taking the medication, such as antiplatelets and anticoagulants. Secondly, we have to make a decision widely when to stop medication, especially emergency operation is necessary. Lastly, we need to think about when and how to resume dose of drug in the future. At this point, we must think about two opposite concerns like Janus pace. One is the risk of hematoma enlargement due to hypocoagulopathy by taking medication. The other is thromboembolism due to hypercoagulopathy by stopping medication. We also have to identify the intrinsic and the modifiable factors altogether based on hematoma expansion and thromboembolism. As a first step, it is very important to figure out the different action mechanism of each antiplatelet and anticoagulant in detail. As you know, there are several antiplatelets such as aspirin, clopidogrel, and ticagrelor. For example, aspirin needed 3 to 4 days to reach a half-life. Understanding laboratory monitoring on each drug is a very crucial step to access operability. Clopidogrel and plasgrel can be checked by using P2Y12 receptor. As you know, warfarin needs 25 to 60 hours to be eliminated. Heparin is 30 to 9 minutes. Another NOAC group has around 10 hours. The most important thing is to know how to reverse each antiplatelet. As everybody knows, vitamin K is antagonist to warfarin, idarucizumab to dabigatran, and protamine sulfate to heparin. Diagnostic tests should be matched to each drug appropriately. INR for warfarin and APTT for heparin. For direct factor 10A inhibitors, such as rivaroxaban, apixaban, and endoxaban. Prothrombin time is used as a diagnostic test. I would like to introduce the meta-analysis papers to compare advantages between NOAC and warfarin, published in JAMA Neurology 2013. As you see in the table, NOAC use has the more beneficial effects over warfarin based on 6 randomized control study. So, NOAC can be considered the first line for the patients at high risk for intracerebral hemorrhage. As I mentioned before, we have to balance two opposite aspects between the risk of hemorrhage and thromboembolism. What is the guideline for the management of spontaneous ICH? In the time of 2015, avoidance of long-term anticoagulation with warfarin as a treatment for non-valvular atrial fibrillation is probably recommended after warfarin-associated spontaneous lobe ICH because of the relatively high risk of recurrence. The usefulness of dabigatran, rivaroxaban, or apixaban in patients with atrial fibrillation and past ICH to decrease the risk of recurrence is uncertain. Let's go through the drug switching strategy between vitamin K dependent anticoagulants and NOAC. In case of changing VKA to NOAC, about 3 days are necessary. INR level is very important to adjust NOAC starting day. On the other hand, from NOAC to VKA, VKA can be started immediately or next day. INR level should be checked 3 to 5 days later, and then NOAC intake can be regulated according to INR levels. I would like to show my experience of surgical cases. 70 years male patients who has been taking a NOAC for 5 years due to atrial fibrillations. You can see the increased hematoma 1 day after follow-up CT scan in the left frontal base. As you see, there is no active bleeding after craniectomy and no de novo bleedings here and no difficulty for hemostasis for bleeding focus. So I could finish the successful hematoma removal without any complication related to the surgery. So I would say NOAC medication doesn't look dangerous to operability. This is my personal opinion. Let's look over real situation how to use antiplatelet and anticoagulant before and after surgery in the real world. These papers published in Germany in 2018. 141 German neurosurgical institutes were invited to participating in survey. Very surprisingly, there was no defined policy for the perioperative management of anticoagulants and antiplatelet around 60% because of the lack of prospective and limited retrospective data. Let's look into more detail. Questionnaires are like this. For example, do you have a defined protocol for the perioperative management of anticoagulation and antiplatelet, and etc.? These all questions are very important to make a treatment strategy for the patients with TBI. I'd like to show the response regarding the first questions. Almost German Neurosurgical Institute stopped medication before surgery around 4 days and resumed medication around 3 to 7 days after surgery. There are many diversity in timing of stopping and resuming, as you see, depending on each drug and each institute. This is flowchart of Marshall University in Germany. If there is a positive findings in CT scan after head injury, they are checking all available laboratory tests and then hold all anticoagulants and antiplatelet. After that, each steps are followed by the result of lab data. I would like to introduce one paper published in 2018, which is a systemic review and meta-analysis. The authors try to determine the adverse outcomes following resumption of anticoagulants in patients with anticoagulation-associated ICH. They conclude that resuming anticoagulant therapy after anticoagulation-associated ICH has beneficial effects on long-term complications. This is a very important slide. Let's see some review papers more about resuming time points of antiplatelet published between 2015-2017. 10 to 30 weeks are optimal timing of resumption of warfarin after ICH in patients without specific underlying disease. 7 to 8 weeks are optimal timing of points anticoagulant treatment after ICH in patients with atrial fibrillation. However, the patients have serious underlying disease of thromboembolism. The resuming time points of anticoagulation should be shortened within 2 weeks. Roughly speaking, I would say restarting anticoagulant after 2 weeks looks safe in terms of balancing thromboembolic versus hemorrhagic complications. Another papers are introducing management strategy when to resume anticoagulation after TBI. Heparin can be started safely 1 day after in case of low risk of thromboembolism. Another drug like warfarin and NOAC and antiplatelet can be reinitiated 7 days after TBI. But if the patients have a high risk of thromboembolism, the time of resumption must be shortened according to the patient's underlying disease. In conclusion, first, there is no clear strategy for the management of patients with TBI with pre-injury antiplatelet use. Further prospective randomized trials are necessary to recommend an effective treatment protocol in the perioperative period for patients with TBI. The use of NOAC decreased the rate of post-traumatic ICH, and they are recommended as a safer option compared with warfarin. Secondly, the resumption of antiplatelet in patients with TBI is an individual issue, depending on the risk of thromboembolic events. The first option in chemophilaxis after TBI is heparin, which can be safely started after stable CT performed after 1 day. In case of patients at high risk of thromboembolism, early restarting of antiplatelets, even 3 days from TBI, might be justified. But the optimal time window for antiplatelet resumption is 7 to 10 days from injury. Lastly, The increasing use of antiplatelet and anticoagulants in the elderly populations deserves particular consideration in precision medicine approach to the management of TBI. Thank you so much for taking your time.
Thank you, Professor Sung-Pil Joo. I have one question. I suppose you have already mentioned partly about it. We often face this tricky situation wherein patients with mitral valve replacement, especially the metallic valves which were used in earlier decades, if such patients have a head injury or a ICH, then what is your practical experience on the use of bridging therapy with heparin? Because if the valve is a metallic valve, there is a very high probability of thromboembolism. So do you recommend that you do the surgery and then immediately after 4 to 6 hours you start on bridging therapy with heparin?
Yes, right. That's very important questions. In case of mitral valve replacement, we know there are high risk of thromboembolism risk. So after any surgery, we need to shorten the time of resumption of like a warfarin. In my experience, I usually discuss the risk of the hemorrhage associated with the warfarin with the cardiovascular surgeons. If there's no some debate between two doctors, we started the anticoagulant within 3 days.
Okay. Dr. Hitesh Gujar has a question that do you see any role of IVC filters in patients who are prone to thrombotic episodes and you have stopped the anticoagulants?
I'm sorry, I don't have experience. Anybody
Okay.
here experienced?
I do not have any experience.
I also don't have.
In such situation, of course, IVC filter is an option, but we had no experience with such kind of patients. Fine. So thank you, Professor Sung-Pil Joo, for your time and nice video presentation which you made. With this, we come to the end of this webinar on the platform Asian Australasian Society of Neurological Surgeons. I thank sincerely to all our esteemed speakers of the day, Professor Eiichi, Professor Cherian, Professor Namkyu, and Professor Sung-Pil for their wonderful presentation and the time devoted. My special thanks to Professor B.D. Sinha for collaborating with all of you and making this webinar possible today. So with this, we call it a day. Professor Sinha has a few words to say.
And again, I want to thank all the speakers because the antiplatelet management is a very common problem day by day as age is advancing. So both of the speakers, Eiichi and Sung-Pil Joo, has covered very nicely this topic, and it's very useful, especially for the everyone, not only for younger, for everyone. And intraoperative ultrasound in TBI is a very important introduction of new and for the management of TBI patient. And I think this is a very good way when we can detect the hemorrhage on the opposite side, as is shown by lot of his cases. And it will definitely now, I will incorporate this ultrasound in my department now. I'm going to start. And Dr. I.P. Cherian, as usual, he's a good teacher and is a good surgeon also. And his cisternostomy is a lot of people are adapting now. And I'm also want to have a project with him about this cisternostomy in my department. So thanks everyone, and I hope we should keep on meeting very frequently. We should share our knowledge so our all patients get benefited of our share of knowledge. Thank you everyone, and Have good time. Have good New Year 2021. Thank you, everyone. Thank you. Thank you. Thank you.